We move on to the next topic for the session. The most important is the panel discussion on hypertension. For that, may I request the moderator, Dr. V. Madhavan, who is a senior consultant diabetologist, interventional cardiologist, Kaveri Hospital, Vadapadani. He is the director, Diabetes and Heart Specialty Clinic, Virukambakam, Chennai. He is the director of SPM Hospital, Ashok Nagar, Chennai. A star awardee of Diabetes India and also Diabetes India in 2015. The Best Doctor Award, Stanley Medical College of Government, Tamil Nadu in the year 2022 and 2023. He is going to moderate this wonderful session. May I invite the moderator to the stage. Over to you, sir.
Good afternoon, each everyone. I have to thank the organizing as the scientific committee of the DCON 2026 for this invite, and I thank the chair. No chair. So I thank for the wonderful introductions. So let me go on to the topic. So we are going to focus the importance chapter, what is called the silent killer. So hypertension. I say it is not a silent killer, it's a silent architect of that invite your heart to go for heart failure. There's an architecture that designs your hearts to go for a failure mode, go for invite heart attack and stroke on. Instead of calling a hypertension silent killer, it's a good thing term is silent architect of inviting all the diseases and things. And if you understand the hypertension scenario in India, it's very, very alarming. Nearly around 220 billion people are affected, million people are affected with hypertension. Out of 420 is having hypertension, and 50% of patients does not know they have hypertension. Even the people on treatment for hypertension does not reach the target of what we have specified for the individuals. That is a worrisome factor. It is easily treatable. It is not the problem with the medicine. It is a problem with the diagnosis, it is the problem with the follow-up, and the problem with the adherence to the therapy. So much of pitfalls is there. Especially when you underlay people with hypertension, whether young or old, they say when the BP comes to normal, they want to stop the medications as like they do for a fever or they do for headache. So you have to impart a knowledge that is a long-lasting disease. You have to take the medications, even the BP is reached under controls. To unlay the focus on various spectrums, how you are going to manage the BP in heart patients, both on heart failure as well as hypertension, and how you are going to handle the BP on kidney aspects, how you are going to handle the hypertension in elderly patients, and only in female, especially women of childbearing age or gestation people, how you are going to handle. We have a stalwart experts. So first I invite Dr. Manikandan, who is a cardiologist, senior assistant professor working in Madras Medical College. He has a professional expertise of done more than 5,000 angiograms and angioplasties and did more than 300 pacemakers and performed more cath labs and structural interventions in government sectors. An experienced interventional cardiologist and academician with an extensive expert in diagnostic intervention cardiology and device implantation and structural heart interventions. I invite Manikandan to come and occupy the chair. I invite Dr. Priya Mali, who is an associate consultant of geriatrics and a senior consultant diabetologist, is having a clinic at Kalatur, and he is ENT and Premaskan ENT and Diabetes Center, and he is a principal investigator of various clinical trials, had good reputed several publications in national and international, is one of the teaching faculty in Tamil Nadu Medical Universities and one of the organizing committee of the DICON Southern Chapter and RSSDS. He is a gold medalist in MD, Best Doctor Award from the government sector from KMC as well as MMC. He is a geriatrician, is going to highlight and hypertension management in elderly patients. Next I invite one of our good friend, Dr. Sumita Sriram, is a senior obstetrician gynecologist and laparoscopic surgeon, director SPM Hospital and Arjun Nursing Home, Chennai. He has a vast experience of 20 years in the field of obstetrics and gynecology and fellowship in minimal access surgery. He is a member of FOGI, OGSSI and so much of academic feats. And academic activities and more of faculty in many of the stalwart OBG conference across our India. And field of interest is high risk obstetrics and minimal invasive surgeries. Next in line, I invite Dr. Navneet Mohan, who is a consultant nephrologist and renal transplant physician and alumnus of AIIMS, New Delhi, is a gold medalist and Best Doctor Award from Department of Medicine, AIIMS, and cleared European specialty examinations in nephrology and holds various posts as a membership of various professional organizations. His special interest is renal transplant and peritoneal dialysis and hemodialysis, and current affiliation is attached to Asian Institute of Nephrology, Urology in Chennai. So let us move to the topics. So any questions from any audience, we invite, because we can utilize the expert panel who can give their insights, whatever clinical dilemma you face in your day-to-day practice. So the questions are framed in such a way that each and every physicians get benefited. So it's not going to in-depth about the medication, in-depth about the disease. We wanted to throw the importance of hypertension management at your clinic or a primary care centers. The first question, Dr. Manikandan can answer. In a patient presenting with a STEMI in a primary care level, not at a tertiary care level, it's primary care level. When a physician diagnoses the patient with STEMI, we routinely administer loading dose. We often give statin, 80 mg, clopidogrel, aspirin to reduce the mortality. So should we consider, whenever we check the pulse may be of 120 or 130, or BP may be 170 or 180, should we consider initiation of any cardioprotective therapies like ACE inhibitors, low dose, or your high heart rate may have a problem for the increased mortality, patients may go for a VT. Is it judicious to use a beta blocker at a primary care level, and should be referred to the patient to the nearest center?
So, good morning to everybody. So this question, the primary aim in STEMI is to establish the reperfusion. So that should be our prime motive. So only we are giving the loading dose, that is we are giving dual antiplatelets, aspirin and clopidogrel, in order to inhibit the platelet activation and to stop the platelet aggregation. So that is the prime aim. This question, whether ARBs or beta blockers can be given as loading dose, we should be cautious in giving them, because beta blockers, when the patient, STEMI patient, is suppose he is in cardiogenic shock, or is having a low BP, or is having some bradycardia or some AV blocks, without looking into that ECG, we cannot give the loading dose as beta blocker. After ruling out this contraindication, if patient is having a hypertension and he is stable, then beta blockers can be given, because they have some proven benefits. They reduce the infarction size and prevent arrhythmias, and that is a cause. But we should be cautious in administering it as a loading dose. And ARBs also has an established evidence. It prevents the remodeling of left ventricle. But it should be initiated within the first 24 hours, not at loading dose.
So very good. So we have a statistical data to support loading dose when you diagnose STEMI, but we don't have any scientific rationale to start or give a loading dose of ACE inhibitor or ARB or a beta blockers, but it has to be started as early as possible in ICU settings. Whether the patients land up in a cath lab center or non-cath lab centers, these medications have some time to initiate. Even the BP is 170 or 190, you can wait. These medications can wait. So it does not have a class 1 indication, has like a loading dose what we give once you diagnose the patient with STEMI. Next question is Dr. Priya Malini. For elderly patients, the current hypertension guidelines recommend different blood pressures. If you go by AHA, ADA, and so much of things, whenever we see elderly patients, the target is different. We are confused. So we could not able to follow what therapy for these patients. Some patients may come for 75 years, active, very active. Some patients have 75 years having so much of cognitive impairment, physical disabilities. How you are going to set your target for these individuals, depending upon the age, frailty, other comorbidities. In your practice, how do you individualize the BP goals for a robust versus frail older patients? What factors most influence your decisions? What are the factors will consider these medicines it suits for these individuals?
Morning, one and all. I would first like to thank the Deacon for this opportunity. Yes, coming to elderly population, we know the population is growing and we have huge sector of people above 60 years. Now, when it comes to management of hypertension and diabetes, so we have to individualize targets. We know we have n number of guidelines, the American Heart Association and the European Society of hypertension. So every guideline says a different thing. So mainly when it comes to a practical purpose, so you have to analyze an elderly person as a whole. So you have to categorize them. It's not the numbers we have to treat, it is the patient as a whole. So you have to look into the functional age, where even Rajkumar sir was talking about the vessel age. So always look into the vascular age. as well as the physical fitness. So even, the AHA guidelines itself tells us it divides into fit or robust individual above 65 years and very old or independent frail individuals above 80 years. So you categorize, so you have to analyze the elderly person as a whole, do a functional assessment. What we tell is a comprehensive geriatric assessment where you can decide what is the memory of the individual, what is the cognition of the individual, any risk of falls is there, or patient is having multiple morbidities, patients on multiple drugs. So you have to analyze the patient as a whole. First, you analyze them, you fix up targets. So target fixing is very, very individualized in elderly patients, especially when it comes, when think about hypertension. So do no harm. And also calculate the life expectancy of a particular patient so that when your risk benefit versus the balance between disease as well as benefit of decreasing a cardiovascular risk or preventing a stroke or decreasing a mortality and morbidity becomes very, very important. So you analyze, fix your target, and then you categorize, you choose your drug. So choose drugs, not too much of long-acting drugs or high-dose fixed drug combinations. So you have to go very, very slow in them, and also monitor them. Monitoring is very, very important. So monitoring for hypertension, especially postural hypertension or orthostatic hypertension is very, very important. So whenever you check BP of an elderly patient, please do both the testing. So I tell you the sitting position as well as standing position. Any drug, it's not only alpha blockers, any drug can produce a postural hypertension. So that increase the risk of falls, patient might have dizziness. So you go into a cascade of events. So trying to treat one illness, you go into a cascade of events. And also monitor for other complications. For example, all the electrolyte disturbances, and sometimes if you have volume depletion with diuretics kind, you can even end up in AKI. So all these factors has to be kept in mind. So choose the right drug for the right patient, analyze them, fix up targets, start in very slow doses. This should be the ideal target.
Yes, we'll come to that. What is the target you want to fix for healthy older individual? What is the target you want to fix a frail individual of a similar age? Yeah. Suppose 8 years walking to your clinic is having no that much of light diabetes, something else, kidney parameters are normal. What is the target you want to fix? You want to fix as like sprint trial, you want to keep the BP of less than 120/80, or you want to have some sort of less stringent control?
Yes, sir. So if the patient is going to be fit, whatever be the age, I would prefer to maintain the BP target is around 130/80. So I will start, I can start with even non-pharmacological measures, but only it exceeds 140/90, I will start with pharmacological measures. So if it's going to be very frail individual, I will titrate. My target will be a little more. I will try to maintain my systolic between 140/90, 140/150, and the diastolic should not go below 60. That's my opinion.
Good. So any elderly patients very active, we can target the BP of 130/80 if there is no contraindications because of the medications or other comorbids. If there is frail patients, you can have some sort of lesion, you can target the BP of 140 and pay attention and drop in diastolic BP. Many of the people may have isolated hypertension. Whenever you push the systolic BP to lower zone, the probability of diastole goes to lower, more common. Next for Madam Sumita Madam, this is an obstetric angle. Who should be screened more intensively for hypertension in a pregnancy? Many of you are seeing many of the ANC patients whom you wanted to intensively screen for hypertension in pregnancy, and what are the current recommendations for the BP surveillance?
Good afternoon, one and all. Thank you for having me here. In pregnancy, sir, it's a universal screening. We do check blood pressure for all pregnant women regarding whether they have risk factor or not, sir. Because anytime we can identify hypertension in pregnancy. And for intensification, when women has higher risk factors, like major risk factors, when they already have a hypertension history, or they are on they have diabetes or a kidney disease, autoimmune disease, or in prior pregnancy they had history of preeclampsia, we intensify the surveillance, sir. And also if the woman is first time pregnant or her age is less than 19 years when she becomes pregnant, or more than 35 years, or if this pregnancy is an IVF pregnancy, it's a multiple pregnancy, we intensify and increase the surveillance, sir. And our current recommendation is, if the blood pressure is more than 140/90 millimeter mercury, on 2 occasions, 4 hours apart, we categorize them as hypertension in pregnancy.
Okay. So next is for our friend nephrologist. This is the place where we are having so much of stucks whenever we treat, because high BP, nephrology patients will come with high BP, but we could not able to give all the medications at par because kidney will not be acting friendly to reduce the BPs. Here's a patient, the stage 3 CKD, which is commonly seen, all diabetic individuals, all the physicians may see EGFR around 45 to 60, the CKD stage 3. When already patient will be on taking 3 hypertensives. So other way around, this is called resistant hypertension with a diuretic, yet BP remain uncontrolled. So how should I approach these patients? What are the common reversible causes I have to look in these patients, and investigation that should every physician consider before escalating therapy?
So good afternoon one and all, and at the outset I would like to thank the organizers D Club, Natarajan sir, and obviously our moderator also for all these very good clinical scenarios which are very common. So this is a very common scenario, right? So you have a patient with uncontrolled hypertension. So the commonest cause, whether it's a renal patient or not, would be actually volume overload. Sodium retention is actually the most common cause, followed by RAS activation, sympathetic activation, in that order. So the first thing, the most important thing is to take the history. So the commonest cause for uncontrolled hypertension is actually patient non-adherence. So you might be writing many drugs, but many times the patient will not be taking as per your prescription. You might have written BD or TDS, patient will be taking only once. See, I've had even patients who say, sir, I never had headache, so I never took antihypertensives. So patients have this thinking that they need to take antihypertensives only if they have symptoms like headache. So you need to ask whether they are actually taking the medications as per your prescription. Second would be the diet. So whether they are compliant with the salt restricted diet advice which was given. So what misconception many patients which they seem to have when I see is, they think that they need to decrease the salt in the food that is in the rice. But they'll be taking pickle, they'll be taking dried fish, and they'll be taking savories from outside. So you need to ask them to cut all these added salt which they have in their diet. Then do a small examination. Many of these patients might be having volume overload. They might be having pitting pedal edema. They might be having engorged veins or even crackles. So many of these patients would need a good dose of diuretics. I think I have a question on diuretics. At that time I will elaborate more. Many times if you have a patient who was doing well till then, his BP was well controlled, was all doing well, suddenly he comes to your clinic and his BP is gone up. Look at his drug chart. Many times I've seen that they would have taken an NSAID, that is some painkiller recently. They would have been started on steroids recently. They'll be taking some decongestants. They'll be taking some pseudoephedrine or phenylephrine or some cough syrup, or started some alternative medications. So that would be the reason for the acute rise in BP which you would be seeing. So more than 80% of the time this would be actually the cause. So if you have ruled out all these things and even then the patient's BP is truly high, then you have to look for the other causes like renovascular hypertension or some endocrine causes and all those things. And one other important cause which we tend to overlook is actually obstructive sleep apnea. So if the patient is very obese and is having a resistant hypertension, you're giving 3 drugs and even then his BP is not coming down, do a polysomnogram and see if he's having obstructive sleep apnea. You treat it, most of the times his BP will come down.
Good. So from this first, we have a data to support loading dose in MI, but we don't have any data to support. We have mortality benefit by introducing a ACE inhibitor or a beta blocker, but that should not be done as OP settings. So we can give loading dose as OP setting, but you should not, whatever the BP with MI, come to your clinic or a ER, don't give that medications. Please admit the patient and then you can initiate the antihypertensives. That is a lesson learned from our cardiologist. In geriatric perspective, we assess the patient as a whole, respect his vascular age, and depending upon the other comorbidities, other conditions, you have to set the goal. So not for all this, one size does not fit for all. And for obstetrics, the surveillance is very, very important. You have to accept the red flag signs. Who are the patients are prone to develop hypertension? How you are going to monitor these patients? Whenever the BP is more than 140 or 90 in 2 consecutive events, these are the ideal candidates for initiation of the antihypertensives. Regarding CKD patients, which we commonly see, you see as a reversible causes. Pay attention on the complaints of the medications, pay attention on the diet, the complaints of the diet. Next, assess other reversible causes like obesity, OISA, and so on. Next, only you can go for other sophisticated investigations. Don't jump directly to investigations. Pay attention on the history, whether the complaints, the medications, and the food is very good. Whenever you jump for a next investigations to address hypertension. Next is what is your opinion on beta blockers? Because beta blockers, many of the times, as a physicians, we have some sort of disturbance in introducing a beta blocker. We are comfortable with ACE inhibitors, ARB, calcium channel blockers, but when it comes to hypertension, and the Indian subset, we see high tachycardia. The patients comes to our clinic with BP of 150/90, high sympathetic activity, pulse may be ranging in the 90. But whether I can start this patient on beta blocker, because many of the guidelines are not supporting, because the first line of hypertension management, even second line, many of the guidelines don't support. So beta blocker is kept as a reserve for treating hypertension. Many of the Western guidelines, even Indian guidelines shows that. So what's the opinion on reducing the CV risk in a patient with high BP? Do you have any preference for beta blocker or in this hypertension management?
Sir, as rightly said, beta blockers are not the center stage drugs as per the guidelines. So only other three drugs, the diuretics, ARBs and long-acting calcium channel blockers are the drug of choice in hypertension. But there are some specific subsets. Patients having established CVD, cardiovascular disease, or patients having reduced EF, heart failure. In that patient, there are some compelling indications to use beta blockers.
We are focusing on, suppose diabetic with high risk CV events. The patients are get benefit of HL inhibitors.
Yes.
These patients are ideal candidate for GLP. As like high cardiovascular risk, hypertension with obesity, smoker, high sympathetic activities. Can you initiate beta blockers as a monotherapy or a second line after ACE inhibitor, ARB as per the guidance? Can we initiate, updated the beta blocker as early as in the course of management of hypertension?
Yes, sir. Some young patients with increased sympathetic activity and some patients with metabolic syndrome, this especially this beta blocker nebivolol has some vasodilatory effect. It has some proven benefits in this metabolic syndrome. But without any other compelling indication, beta blockers are not the first line drugs in hypertension. All the other three drugs should be first tried, and in resistant hypertension it can be tried.
So when there is evidence of high sympathetic activity, there is a role for beta blockers, and all the beta blockers are not same. So you choose a highly cardioselective beta blockers like nebivolol or some other bisoprolol and all that can have minimal side effects on the metabolic parameters, or minimal side effects on other COPDs, other components. So there is a role for beta blockers. I'm not here to say the beta blocker has to be started first. So pay attention to the clinical scenario of the individuals. If there is a need, if there is high evidence of high sympathetic activity, if there is high evidence for the patients can go for heart failure, a stable angina is there, you can give some sort of low dose beta blocker if it's warranted. For geriatric senses, many geriatric patients receive 4 or 5 medications, maybe having a diabetes, maybe having some sort of arthritis, or so much of things, maybe have many parameters, may coexisting illness as age advances, and these patients also have decline in GGFR. Age itself a parameter that can decline EGFR, can have a negative impact on the hepatic clearance. So whenever we want to start the medicines, we have a awareness whether this drug will interact with my drug in terms of BP reduction, this drug will produce any problem in the kidney or renal angles. So how we are going to balance the BP control, at the same time we want to have an optimal BP control.
See, when it comes to geriatric population, multimorbidity is very, very common. So the multiple comorbids, so patient is on multiple drugs. So polypharmacy becomes a very important issue we face with the geriatric population, as well as age-related changes, increase in arterial stiffness, the baroreceptor mechanism goes off, and you can have a decline in EGFR. So all these factors put together, it becomes a very task to treat a geriatric population. So the main important thing is always assess the renal functions. So when you are starting a new drug, you assess the renal EGFR. Don't go by the creatinine values, because in the geriatric population there is a decrease in muscle mass. So the creatinine will not guide you for the drug dosing. So you always go by the EGFR levels. And drugs which have which acts more on second phase of hepatic clearance, because the first phase of hepatic clearance is decreased in elderly. So those who have an effect on the second phase of, so choose drugs like that. And when it comes to polypharmacy, so it's better that first you choose a single drug which you have multiple actions. For example, if an elderly male is having a prostate issue with hypertension, you can go for, though it is not a first line of choice, you can choose an alpha blocker when compared to other drugs. So choose one single drug with multiple effects and try to review the medications, and always you think about de-escalating drugs, de-prescribing drugs. So always there is a prescription cascade. For one main patient would have given amlodipine for BP control, we developed a pedal edema, then he would be started on diuretic by another person. So they visit multiple consultants, and over-counter drugs are also possible. So when how do you really manage them is that first you review all the medications. That's very, very important. You ask them to bring all the medications given by multiple consultants. You review the medications. And when you start with very, very low doses, go very slow and try to monitor them. That is more important. And always look into for side effects of treatment, like when the patient is developing pedal edema or hypertension, and try to de-escalate the drug. So choosing the right drug for the elderly is very, very important so that you avoid complications. Mainly we are talking about the hypertension and falls. So, and a fast decline, a rapid decline in BP is also to be avoided. That is more important, because we know there is a risk of confusion, delirium, because of the cerebral perfusion being impaired, and also a cardiac compromise can also occur. So we can precipitate a MI rather than decreasing a cardiovascular risk. So rapid decline to be avoided. Low dose combinations, start very slow and go slow, and monitor for drug therapy.
Very good. So the primary point is start low and go slow, and see the other prescriptions what the patient is taking on. If possible, add a medication that can have a synergistic effect on the primary illness, as told by madams. So, and obey the contraindication, use the indication of the medication and obey the contraindication of the medication, because these patients have decline in EGFR, decline in hepatic clearance, though drug toxicity may be very high. So usual dose cannot be updated or applicable for elderly patients. You have to go slow only. And for obstetric angle, how aggressively should be BP lowered without compromising uteroplacental perfusions?
Sir, if the patient is in a mild preeclampsia where a blood pressure is around only 140/90, our target is it has to reduce the blood pressure on 135/85. We start them immediately on antihypertensive. But if the woman is in the severe range of hypertension where a blood pressure is around 160/110, these are the women who require admission, and we monitor them every 50 to 30 minutes, and we try to reduce the blood pressure within 1 to 2 hours. That will reduce the maternal as well as the fetal complications. It has to be a prompt reduction, but it has to be gradual. It should not be precipitous, because it will cause fetal distress in the baby as well as maternal complications.
So depending upon the clinical scenario, you have to be aggressive or maybe non-aggressive. And you have to assess the clinical conditions.
It's a mild or the severe range. Mild is
you can
we
wait.
can follow them up.
Okay. For nephrology friend, so we have renovascular hypertension often considered reversible causes. Many of the times we advocate go for renal stenting, as we do with coronary and carotid stentings. There are many guidelines says you can go for renovascular hypertension, can be a reversible cause potentially. You can go for stenting, so renal stentings. But many of the latest Astral, Coral trial has not given that much of weightage. That is, renovascular hypertension treatment by stenting is not that much efficient as like a optimal management. So what are the red flag signs that should be make a general physician to suspect these patients having renovascular hypertension? How should we investigate these patients, and which patients still clearly benefit with renal revascularization?
So again, I like that sentence very much, sir, but it can also be over-investigated. That is very true. So whenever we talk about renal hypertension, so increased blood pressure because of the kidney is primarily because of a chronic kidney disease or a chronic glomerulonephritis rather than a renovascular hypertension. So whenever we say renal hypertension, many times it is CKD rather than a renovascular hypertension. Actually, in practice, less than 10% of the renal hypertension patient would be because of renovascular hypertension. That is because of renal artery stenosis. So that's why I think that sentence is very much important. So for whom do we really think about renal artery stenosis? So patients who come with very severe hypertension for the first time, especially when their age has been above 55 and are having other atherosclerotic diseases, because the commonest cause for renal artery stenosis is again atherosclerotic renal artery stenosis. Or you have a very young female with where you can suspect fibromuscular dysplasia, then you would consider. Or patient who is having recurrent flash pulmonary edema. Or in patients where they are having unequal kidney sizes. So they do an ultrasound, the kidney sizes are unequal. And in patients who have a progressive deterioration of the renal functions, or you have started them on AC inhibitor or ARB, and suddenly their creatinine rises by more than 30%, let's say by around 50% and all those things. So only in these patients you would really consider renal artery stenosis and then investigate them. Now, investigating for renal artery stenosis is again an issue, because the commonly used investigation is a Doppler, which is highly operator dependent. So it might not be really the best test to really diagnose renal artery stenosis. So if you have a very high clinical suspicion and you are really planning a intervention for the patient, you might have to go for CT renal angio or a magnetic resonance angiogram. The only problem is when you go for a CT renal angiogram, you'll have to give contrast. And if the patient is already having renal dysfunction, then again that plays on your mind. But to be very honest with you, if you are clinically you have a very high suspicion and you feel this patient would need intervention, intravenous contrast should really not be a deciding factor in not giving the investigation to the patient, because that will change the outcome for the patients. Or if you are really very much worried about contrast, you can go for magnetic resonance angiogram. The latest gadolinium is really not a problem, but again, you'll never know what type of gadolinium the lab is using. So you can go for time of flight sequence where no contrast is really necessary. But the gold standard would always be a digital subtraction angiogram. And at that time, you will do the stenting as well. The only issue is, as sir rightly pointed out, most of the trial data right now really does not stenting for every renal artery stenosis. So there are specific indications where renal artery stenosis would be really considered. Number one would be a recurrent flash pulmonary edema. That is, the patient is coming to your ER again and again with flash pulmonary edema and is having an accelerated hypertension. So these patients, if they are having a renal artery stenosis, might benefit. Patients who are having resistant hypertension, that is, you have given them more than 3 classes of drugs and even then their BP remains above 160 or 180 and you are just not able to control the BP for these patients. The third category would be patients for whom they are having progressive decline in their renal functions. That is, their eGFR keeps falling in spite of you being able to control his BP. For these patients, you might consider a stenting. To be very honest, in practice, not even 10 to 20% of the patients would be actually fitting into any of these categories. Most of the patients with the modern medications which we have will have good blood pressure control and will not have any of these issues, then they may not really benefit from stenting. So it's not that you see a renal artery stenosis in Doppler, everyone should be stented. That's not the case.
Good. So renal vascular hypertension is one of the reversible causes commonly seen in people young age. So whenever there is evidence for any atherosclerotic events, any other arteries, you may suspect renal vascular hypertension, or evidence for fibromuscular dysplasias, or patient recurrent admission for accelerated hypertension, flash pulmonary edema. Please pay attention to assess renal vascular hypertension. One of the more golden modalities is digital subtraction angiography. Even ultrasound can have an evidence of some sort of things. And all the patient, as we do in coronary, the stenting is not beneficial. That is the things we want to know it. So presence of renal artery stenosis does not mean the patient is a candidate for stentings. Please pay attention to optimal medical management. We have good molecules in our hand that can reduce the BP, that can increase the survival individual, not only putting a stent across the renal artery as we do in coronary arteries. So third, how do you determine the optimal timing of initiation of beta blocker in a patient with reduced heart failures? So when the patient, now we are going for hypertension and we know what is the role of beta blocker in MI. Now we are paying attention, reduce ejection fraction patients, because many of them comes with pulmonary edema, breathing difficulty, V's will be there. But heart rate is also very high. So when you are going to start beta blocker and how you are going to up titrate the patients?
So this is a very good question. So as we know, there are 4 pillars in the treatment of heart failure with reduced ejection fraction: beta blockers, the ARNIs, and the SGLT2 inhibitors, and MRAs, mineralocorticoid receptor antagonists. So of this, I think the next question also we are going to discuss this. So first, in this question we will discuss about this beta blocker. When the patient is first presenting to you, we have to assess the hemodynamic status. If the patient is hemodynamically stable and his kidney function is also good, then the safest drug to initiate first will be the SGLT2 inhibitors and IV diuretics. First, we have to decongest the patient and stabilize the patient. And after 48 hours, we have to see whether he is hemodynamically stable. And as I said in first question, we have to see the ECG. There is no bradycardia, or there are no AV blocks, and the urine output is good, and the patient has become euvolemic. Then we have to start beta blockers, that too in the lowest dosage. The 3 beta blockers that are approved in the heart failure with reduced ejection fraction are the metoprolol, bisoprolol, and carvedilol. So bisoprolol, we should start with the lowest dose of 1.25, metoprolol 12.5 BD, and carvedilol it should be 3.125 milligram BD, and we have to slowly assess by the second week and up titrate the drug if the patient is hemodynamically stable.
So even one of the 4 pillars of heart failure management is beta blockers. Many studies have clearly showed the initiation of beta blocker reduces the mortality in terms of reduction of arrhythmia and increase the longevity, but it should not be started in acute decompensated settings. So drug has to wait So once there is a evidence of pulmonary edema, you should not start an beta blocker. And every ECG showing any contraindication like more than first degree of block, you should not start these medications. Make the patient euvolemic, decongest the lungs. The priority will be given for the decongestions. Even heart rate is 120, 130. Don't be in attempt to start a beta blocker because that produces worsening act. So when I was doing MBBS beta blocker, when you say the beta blocker is an indication for heart failure, will be failed. Now the beta blocker is one of the gold standard molecules that can reduce the mortality is a scenario now. So in that beta blocker we have time tested scientifically proven molecules. The one is bisoprolol, carvedilol or metoprolol at the lowest start to the titration as depend upon the hemodynamics. Next is aging causes structural changes. As you already told, the vascular aging, we have to respect the vascular age of the individual with more rigidity. So these are the patients, geriatric patients are more prone for isolated systolic hypertension. Patients may come to our clinic with BP of 180 systolic and diastolic of 80. So aggressive titration to reduce the systolic BP may also have a negative impact of reducing the diastolic BP. But many of the times we know that coronary perfusion relies more on diastolic BP. So if you target systolic BP by reducing the diastolic BP, will not produce any problem on the heart of the elderly patients.
Yes, sir, true, sir. So isolated systolic hypertension, one of the common problems we encounter in geriatric population. So when to treat them? So definition is very well known to us that when the systolic exceeds more than 160 and the diastolic will remain low, less than even 80. So when you start aggressively treating them with multiple drugs, you will definitely encounter diastolic drop. So diastolic drop means you are increasing the coronary perfusion risk. So in CAD patients, you keep your target. So here treating, maintaining your diastolic BP becomes the most important target than treating your systolic hypertension. So by reducing the systolic hypertension, we try to bring down the stroke risk and cardiovascular risk. But by decreasing the diastolic BP, you increase the cardiovascular risk. So in a CAD patient, in an elderly patient, you try to maintain your diastolic BP around at least above 70. So otherwise, don't go below, diastolic BP should not go below 60. So the main important thing in you choosing your drug. So we know very well that calcium channel blockers, mainly the non-dihydropyrin calcium channel blockers like amlodipine and nifedipine play a role in bringing down the isolated systolic hypertension. Also thiazide and thiazide like diuretics. So both of them, they will have a very specific effect on the systolic hypertension, and the diastolic fall is going to be very, very low. And one important thing is that the J curve phenomenon should be maintained. So that is also very, very important in an elderly diabetic. And don't bring the white pulse pressure also to be addressed. So choosing right drug is very important, and most important thing is you don't fastly reduce the blood sugar. So rapid decline in blood sugars should also be avoided in elderly population.
So isolated systolic hypertension also carries high mortality. So we have to pay attention to reduce isolated systolic hypertension because that is a surrogate marker for strokes. So when you want to design a treatment, you use the drugs that acts on the vascular tree. So majority of times calcium channel blockers have a beneficial effect in terms of reduction of isolated systolic hypertension without dampening much diastolic BPs. But at the time, every time the patients go for ambulatory BP monitoring or home monitoring BP, ask them to record both the systolic and diastolics and give attention for both the parameters. So drop the systolic, but not to the great extent of diastolic falling below the less than 70. So drugs designed to reduce isolated systolic hypertension has to be used whenever you see a patient like calcium channel blocker or a diuretic, then going for a BP like ACE inhibitors that can have a drop on the diastolic BP also. After this, why is labetalol is considered the preferred beta blocker compared to other beta blockers? In which clinical situations would you avoid labetalol or consider alternative?
Labetalol is the first antihypertensive choice in pregnancy, sir. It has a dual blockade. It has both alpha-1 adrenergic and non-selective beta blockers. It causes very minimal maternal and fetal risk. In mother, it does not cause reflex tachycardia, whereas in babies, it does not cause brady or hypotension or a growth disturbance. And it's also very versatile. We can give it as an emergency also as an IV form or a chronic oral management. It is only thing it is avoided in bronchial asthmatic women or women with cardiac failure, where we consider a second line agents like calcium channel blockers, nifedipine or alpha methyl docas.
So any other beta blockers of choice and the labetalol is contraindicated. So any other choice, metoprolol or something?
Metoprolol we can start.
So labetalol is friendly for both the fetus and mother, so that is becomes a choice one drugs. But we have some sort of lacunae in hypertensive asthmatic patient or some sort of heart failure patients. We don't use labetalol. That the time you can switch over the cardiac selective beta blockers like metoprolol, or there is a way attention, so you can for a non-thyroid dependent calcium channel blockers. So time is only we have 20 minutes. We have to go for another 2 rounds. So I want we have crisp answers. So managing BP in a patient with diabetic kidney disease carries a vital importance. We have to target the BP, otherwise diabetic kidney disease may worsen. Patient present with marginal elevations of renal parameters, subtle elevation of creatinine of 1.8 or 1.9, potassium or 5 or 5.5. How you are going to initiate time tested lipid ACE inhibitors? How much of escalation of serum creatinine can happen when I put this patient on ACE inhibitor or ARB, or even for MRA or non-steroidal MRA for this patient?
So, ACE inhibitor or ARB would be the drug of choice for any patient with diabetic kidney disease, especially proteinuria diabetic kidney disease. And whenever we start these patients on these drugs, there is expected rise in creatinine of up to 30%. So this is almost always expected. And if the rise is more than this, you should always see whether the patient is getting dehydrated. So if the patient is on a diuretic as well, then there can be more rise than which is expected. And even then, if you're not able to explain, look for renal artery stenosis, which we had already talked about. As sir had said, the other most important thing, actually the most important thing in practice is actually potassium. So many times when the patient is having renal dysfunction and you start them on ACE inhibitor or ARB, your potassium tends to go up. So always make sure you tell your patient to take a potassium deficit diet. So me being a nephrologist, I saw so many patients this season, all of them had taken mango. So you do tell them don't take fruits which are rich in potassium, but then the patient will not be following your orders. So always take that history, that's very important. But the latest recommendation is, even if your potassium is going up on ACE inhibitor or ARB, you don't usually stop the drug. You are supposed to give something to reduce the potassium if it's possible. So initially we were using calcium polystyrene sulfonate. Nowadays we have a drug called Lokelma, which is sodium zirconium cyclosilicate. Exorbitantly costly, that's the only problem, but otherwise a very good drug. If your patient is able to afford, you can start your patient on that. So the bottom line is, we would like you to continue ACE inhibitor or ARB unless and otherwise you're not able to give the drug at all.
So I can take that way. The patient having creatinine of 1.8, if I start ACE inhibitor ARB or a non-steroidal MRA, if it crosses more than 30%, I have to look for the reversible causes. First, dehydration or any dietary non-compliance. If the patient is compliant, if the patient is hydrated, I could not able to identify renal artery stenosis, can I stop ACE inhibitor?
Yeah, you will end up stopping. But the first thing before stopping that would be to give calcium polystyrene sulfonate or sodium zirconium cyclosilicate and recheck. But if the potassium is not coming down, even then you will end up stopping the drug.
In the Indian scenario, I think Lokelma is too costly. I think 750 and one sachet is called 750.
Yeah, 500 to 750 rupees per sachet.
It is very too costly because ACE inhibitor is very low. The treatment to come back that is very costly. So can you go for one single drug instead of MRA or non-steroidal MRA or ARB?
Yeah. So usually if the patient is on both, we would obviously stop anyone. So usually we wouldn't have started the patient on NSMRA before ACE inhibitor ARB. So the first thing we would have given would always be an ACE inhibitor or an ARB. And if the patient is doing well and the potassium is normal, only then we would have added the NSMRA. So if the patient is on both and the potassium is high, then you can stop any one of the two. So here comes the debate. So the recommendation is actually to stop NSMRA and continue the ACE inhibitor ARB. But many times if you see continuing the NSMRA and stopping ACE inhibitor ARB is actually easier. Because the finerenone, which is the commonly used NSMRA nowadays, the chance of hyperkalemia with that is lower than the chance of hyperkalemia with ACE inhibitor ARB. But again, NSMRA is much costlier when compared to ACE inhibitor or ARB. So if cost is an issue, you would probably stop the NSMRA and continue with the ACE inhibitor or ARB. But cost is not an issue, and you feel monitoring potassium frequently would be a bigger problem, then do the other way around.
So we have only 17 minutes left. So fourth is, what is your real world algorithm for initiating and updating the 4 pillars of heart failure? Which clinical parameter you take into consideration whenever you want to escalate? So BP, heart rate, sodium, renal function, because many of the drugs acts in the kidney may have a negative impact of increasing hyperkalemia as told by previous talk. But be crisp, because we have only 17 minutes.
So I'll try to be very crisp. So in this starting this 4 pillars, now we follow this rapid sequence algorithm. So we try to get on board all the 4 drugs before the patient discharges from the hospital. So as the previous question, if the patient is hemodynamically stable, there is no inhibition, we can start first SGLT2 inhibitor, we can start either DAPA or empagliflozin can be started safely. Only thing we have to monitor the renal function. So next comes if the patient is BP is holding, systole is above 100, we can start with low dose of ARNI, sacubitril valsartan can be started. The things we have to monitor in sacubitril valsartan combination is BP, again BP and renal function. So as our nephrologist told, we have to monitor whether the EGFR up to 30% increase is allowed, and potassium also should be monitored. And after this IV diuretics and patient is off this inotrope, then we can, in the second or third day, we can start with the low dose beta blockers, and we have to titrate this dose. In this beta blocker, we have to monitor the BP and heart rate. And the last drug, we will try to add this MRA. In HFrEF, we are using this spironolactone and eplerenone. Both are approved for usage. Here again, we have to carefully monitor the potassium, because they tend to raise the potassium levels, and also renal function has to be monitored. And from the second week, we can try up titrating the dose. The maximum tolerated dose should be we have to titrate till the patient tolerates what is the maximum dose, and we have to try to discharge the patient with all the 4 drugs on board.
So nutshell is, whenever the patient is going to get discharged, all the 4 drugs should be there in the prescription if there is no contraindication for the drugs. So all the drugs in the minimal dosage is except SGLT inhibitors, where you can start at the maximum dose of dapagliflozin 10 mg or empagliflozin 10 mg. Other drugs you have to wait based upon the heart rate, volume, congestion and all. So preference is given for volume status of individual, preference is given for the hemodynamic, renal function. And depending on the renal function, you can down titrate or escalate the medications of ARNI or MRA. And in MRA, we have eplerenone as well as spironolactone have an edge in heart rate with the reduced ejection fractions. And every visit you have to pay attention for the baseline investigations, echocardiogram as well as BP, pulse, heart rate. Then you can slowly up titrate the molecules. So next is what is the common cause for treatment failure or not able to reach target hypertension in elderly? Your experience and how do you address them? Many of the times you are not able to attain the target in elderly patients. We have only 14 minutes.
Yes, sir. See, mainly it is non-adherence or giving a suboptimal dose. There's a therapeutic inertia, missed doses. So all these are very common causes of treatment failure. So when we see a geriatric population, that you go for start low and go slow, but go for early fixed drug combination so that you'll achieve your target BP as soon as is possible. And look into other comorbidities also. So choosing drugs based on other comorbidities is very, very important, and not the wrong drug. For example, for isolated systolic hypertension, I can start him on a beta blocker first. So that should be an amlodipine or this. So these parameters we follow, you'll be able to have less treatment dropouts.
Lower doses, you can go for a fixed drug combination that can address different aspects of BP. So if you, instead of going Nicardia 20 mg BD, you can go for amlodipine 5 mg. You can add some other diuretics or some other low dose ACE inhibitor as a beta blocker, depending upon the clinical scenario. So low dose, you can avoid the side effects, and competitive mechanism, synergistic blockade of many alternative mechanism can drop the BP to the target. Next is, which laboratory tend to be more productive of progression of severe disease, whether these patients go for HELP syndrome or these patients go for, what are the laboratory predictor? So I can follow these patients go for eclampsia.
The first one to decrease will be the platelet count, sir. When the platelet count is less than 1 lakh or it daily drop of more than 40,000. Second will be the elevated liver enzymes, which will be twice the upper limit of normal or more than 70, or we see any evidence of hemolysis, where there will be increase in LDH or there increase in total bilirubin, or in peripheral where we see cystocytes, we think of HELP.
So how often you will do in a patient you are treating hypertension with pregnancy, how often you will do in this test?
So if it's a mild preeclampsia, at 28 weeks, once in 2 weeks we repeat those tests. If it's a severe eclampsia or with other comorbidities, sometimes twice a week also we repeat all the blood investigations. Sir.
Any change in medications when the HELP syndrome is happening? Suppose patient is BP is uncontrolled, hemolysis is happening, low platelet is happening,
We have
you need
to
to change the medication.
Delivery is the first step.
First.
We have to deliver the baby, then only control the blood pressure, then we can give them on steroids or depending on the conditions, on the platelets.
So how do you select diuretics as antihypertensive in a patient? I'm talking diuretics as antihypertensive
so-
in a patient with CKD, and when do you switch?
Yeah, so usually, sir, diuretics as antihypertensive, at that stage, most of the patients don't come to me. By the time they come to me, they are already in TKG stage 4 and the EGFR is less than 30.
We'll talk as a physician aspect of stage 3 or 4.
So if it is 3 or 4, usually we go for the thiazide-like diuretics like chlorthalidone or hydrochlorothiazide. That is what usually we give. But again, in an elderly population, be careful about hyponatremia whenever you are giving hydrochlorothiazide. The thing is, if the GFR is less than 30, you want to give a diuretic, prefer loop diuretics. The thiazide diuretics are unlikely to act. If you want to give a thiazide-like diuretic, many times it is metolazone, which comes by the name of Zytanix. The only thing you need to be careful about is in patients with significant renal dysfunction, the diuretic dosage needs to be proper. So you cannot be giving the patient loop diuretic like furosemide of 10 mg or 20 mg or a torsemide of 10 mg or 20 mg to a patient with EGFR of less than 30. It's not going to work. They will need much higher doses. So the doses which needs to be given is furosemide of 40 and above or torsemide of 20 and above. Only when you give at that doses, the patient will have any effect. Otherwise, the patient will not have any effect. Usually, again, loop diuretics is more to decongest rather than for BP reduction per se. You have other effective medications which you can use.
So suppose I'm increasing diuretic, whether it will have a negative impact on the GFR. So many of the nephrologists says, why are you giving diuretics? Diuretics is the things that will increase the creatinine.
Yeah, so that is true, sir. So it comes down to the, it's a balance. So if the patient is having significant volume overload, you will have to give loop diuretics at the end of the day. That will result in fall in GGFR. If you don't want to give loop diuretics, you will have to take the patient for ultrafiltration. Now that is much more difficult to do. So the thing we'll have to tell the patient is again comes to diet control and fluid restriction. So
many of the times as a cardiologist, when we give diuretics, because we have more volume congestions, we want to increase RNE. Because many bit of RNE comes with 200 mg. Because it is very difficult for us to reach 200 mg with heart failure of EF of 25. So whenever we want to escalate, the creatinine jumps. So when we send to nephrologists, they say this drug is producing the problem, this diuretic is the producing the problem.
True.
But we don't have any data to reduce the volume. So that phase, the doctor, patient will say, sir, unga maathram da kidney damage agudante.
No.
These are things we see as a cardiologist.
Yeah, I think we as nephrologists should be a bit more careful in communicating what we see to the patient. So I usually tell the patient that if you are volume overload, this drug would be necessary, and when you take this drug, the chances of your creatinine going up is there. So how you prevent is that you bring the patient to euvolemia and then ask them to stick to the sodium restriction and fluid restriction properly, so that we are able to stop the diuretics. Otherwise, the patient is going to go into recurrent pulmonary edema, and then we'll have to give more and more diuretics, and more EGFR fall is going to be there.
I think there is only 9 minutes whether we can stop, or another 4 questions is there, whether we want to continue or stop. Finish. Okay. So despite last question, despite multiple antihypertensive therapies, many patients fails to have a BP control. In your opinion, what are the most commonly overlooked reversible cause of resistant hypertension? So Manikandan, you can pay attention, give us some insights on resistant hypertension commonest cause. Already told by our nephrology colleague.
I think all points have been discussed by our nephrologist. First, we have to see whether there is pseudo-resistant hypertension, whether there is any error in recording and measuring the BP, like that, any interaction with medications, like that we have to see. And after ruling out all these things, if the patient is having resistant hypertension, we have to look for the secondary causes, the endocrine causes, whether the common causes hyperaldosteronism, Conn syndrome. So you have to measure the plasma aldosterone to renin ratio.
Many of our patients says, whenever I come to your clinic, only my BP is high. How you are going to handle
that? Is white coat hypertension.
How you are going to exclude white coat hypertension? What is your recommendation of home monitoring of BP?
Yeah, home monitoring BP can be done, and ambulatory BP monitoring also can be done.
Do you advocate regularly for it? Because ambulatory BP monitoring is very difficult. So it's do you advocate home monitoring of BP for all your resistant hypertension patients?
Yeah, if the patient is very anxious and patient is having high resting heart rate, then usually we suspect this white coat hypertension, and I will ask them to see the BP. That too, we should properly instruct them. She should not be taking any coffee prior to the measuring the BP. He should should be ideally he should be very calm, and then we should measure the BP.
So resistant hypertension, if you want to exclude white coat hypertension, you can advocate home monitoring BP. But before that, You have to educate the patient how you have to measure the BPs. As told by, you should not consume coffee or any other drinks. You have to sit regularly. Your cuff size should be normal. You should not talk. So much of things you can educate the individuals when you want to do assess hypometric BPs. For time constraint, I'm jumping to the next topic. Are there any recent guidance or updates, clinical trials that have changed your practice in treating geriatric hypertension? What are your first line of medications?
So we do have the recent STEP trial and the SPRINT trial, which says intensive BP control is reducing the CV risk and mortality as well as stroke risk.
Do you accept SPRINT trial target?
No. I mean, practically it is not possible. So we will end up with more of complications rather than maintaining. So when patient has a CV risk and where the patient is fit, robust, independent individual, then you fix up that target of accepting the STEP or SPRINT trial. Otherwise, frail individuals, you fix up your target.
What is the first line of medication?
Yeah, I will prefer thiazide or thiazide-like diuretic. Then I will choose a calcium channel blocker, maybe a long-acting one. So indapamide has a very good role in management of.
How many times patients have developed hyponatremia on diuretic therapies?
I mean, if you go for a very low dose, most of them we don't encounter, sir. So only when we go for loop diuretics, we have those kind of problems, issues.
What is your protocol for fetal surveillance in women with gestational hypertension or pre-eclampsia?
We start the surveillance throughout pregnancy, sir. Then we plan the delivery before 37-38 weeks. If it's a mild preeclampsia, we ask them to come around 28 weeks every week till our planned delivery. We do a growth scan. It will be done at 28, 32 and 36 weeks. We monitor their growth. We check their blood Doppler as well as the Leica and ask women to maintain a daily fetal movement counts and all the lab parameters.
As a physician, when you refer a case to us to BP control, they'll ask, in the BP the first things that mother will say,
baby the first mother.
They will say, how we have to tell to them. So this will not have a problem.
BP control panna we prevent the preterm delivery and also the chances of IUGR fetal growth restriction and chance for NICU admission. So good BP control can protect mother from eclampsia, which is the most commonest cause of maternal mortality in second most commonest cause after the PPH, sir. So it's must.
Okay. So can a non-steroidal MRA be added as AC ARB to optimize BP as well as protein excision if renal parameters are marginally raised?
So definitely add non-steroidal mineralocorticoid receptor antagonist we had already talked about. So the one thing which we have is finerenone. Actually finerenone is never used by a nephrologist for BP control part of it. It's almost always for the renoprotective effect to decrease the proteinuria. But there is a molecule in pipeline. So there's a molecule called as esaxerenone which is actually it is approved in Japan. So it's still not available in India. We are expecting to get it by this year end or the starting of the next year. So esaxerenone is a non-steroidal mineralocorticoid receptor antagonist which has very good data with regard to resistant hypertension management. So Eris is the company which is planning to bring about the molecule. If it comes, then we'll have a non-steroidal mineralocorticoid receptor antagonist which is useful in treating patients with resistant hypertension as well. But as of now, finerenone is predominantly used for the renoprotective effect rather than for blood pressure control.
The esaxerenone is approved by US FDA or not? Because esaxerenone was a drug that came first in 2019, if I am right.
Yes.
But finerenone came later.
So finerenone
has approved by US FDA. Yeah. Esaxerenone has not been approved by US FDA.
Because most of the studies of esaxerenone from Japan, it has approval in Japan and it is available in Japan. It is somewhat similar to cilnidipine. Cilnidipine is also not US FDA approved, but still it's widely available in the market and most of the data is again from Japan. So the reason why it is not US FDA approved is not because of lack of clinical data or some side effects. It is because the Japanese, they have not even filed for FDA approval because it involves loss of cost and all those things. So again, esaxerenone, the data, there is some Indian data which actually Eris is doing a study. We had a recent collaboration, so I know about this molecule. They are planning to bring it by this year end, and most of the data for esaxerenone is with regard to hypertension management rather than nephroprotection. Finerenone is being used for nephroprotection rather than for hypertension management.
Esaxerenone is compared with the aldactone and epilenone, is not compared with the finerenone, even though it is non-steroidal.
So sir was talking about eplerenone and spironolactone. So they are much cheaper. So if the patient is not able to afford finerenone, many times we will be able to give those molecules. The only thing is chance of hyperkalemia are higher.
Okay, thank you all for the, and we are coming to the conclusions. Hypertension is not just a number. is a strong predictor of premature cardiovascular events. The biggest challenge is no longer the lack of medication. We have a good number of medications. The gap is awareness as well as diagnosis and treatment. Every BP measurement is the gateway to prevent heart attack, heart failure, CKD and stroke. Achieve the target BP goal, achieve the target outcomes. No stroke, no heart attack. Let the disease be silent killer, but our response should be never be silent. Thank you very much for the patient listening.
Ladies and gentlemen, that brings us to the end of our morning sessions. On behalf of the organizing committee, I extend my sincere thanks to all our respected chairpersons and speakers for sharing their valuable knowledge and insights, and to all our delegates for your participation. We will now take a quick short break for lunch. Yes, 30 minutes. Kindly reassemble in the hall in another 30 minutes as we resume for our afternoon sessions. Thank you. Have a great lunch. Thank you.